Good morning, everyone. Today we're joined by Dr. Eddie Stenehjem to give our weekly COVID-19 update for the state of Utah. Dr. Stenehjem, as always, thank you for joining us.
Good morning.
So I want to start with case trends and what's kind of been going on since the last time we spoke. The total cases for the state of Utah are 314,817. Yesterday's daily case count was reported at 2,899, which brings our daily rate positive percent to 23.5% and our 7-day rolling average percent to 27.8. Our total deaths in the state of Utah are 1,449, and yesterday there was reported 27, with 9 of those happening before yesterday. In the US, there was the single highest death count in one single day at 4,281. Hospitalizations in the state of Utah have now topped 12,160, with yesterday's hospitalizations at 566, and our ICU referral rate at 92.6. The vaccine distribution is at 1,024,884 people total. And as always, those numbers are reported from yesterday. We do not have today's numbers yet. Let's start there. I want to talk about post-holiday surge. It is January 12th. It's been about 2 weeks since the new year, about 3 weeks since Christmas. Are we through this holiday surge yet?
Yeah, we don't know. So when you look back to Thanksgiving, that's probably the holiday we can kind of reflect on the most in terms of comparison. Our post-Thanksgiving holiday surge was definitely present, but it was relatively short-lived. Occurred about 7 to 10 days afterwards. We saw this spike and it came back down. And so now we're talking about Christmas and New Year's, bigger holidays for the state of Utah. The two holidays together with a week in between, a time when families get together. So I would anticipate that we're going to see probably a longer surge than we did in Thanksgiving, which was just a point event, right? It's really kind of gatherings over a 1 or 2 day period. So, what we've seen is we've definitely seen this holiday surge that started for us really when cases went up right around December 30th. So that was 6 days post, Christmas Eve, which fits pretty well. Then we saw some more, pretty high case numbers coming in, January 6th, which is about 6 days after the new year, which fits pretty well. And now we've seen a slight decline in cases. In addition, what I think is really important for us to also recognize is that we're having a decrease in our test positivity. And so yesterday, I believe it was 22% test positive for that one day. And we've had a 27% now rolling 7-day average, which has really come down to, from 33 or so. And so that's a good sign. It's a good trend in terms of a decrease in test positivity. Nowhere near where we need to be, mind you, but it's not 33, right? And so we're seeing a decrease in that, which usually, can kind of predict a continued decrease in cases. And we're seeing decreases in cases over the past few days as compared to early January. So I'm cautiously optimistic that we've had a relatively limited holiday surge and that we're still going to come down. The next couple of days, I think, are going to be really telling in terms of whether or not that is a sustained reduction. But cautiously optimistic, test positivity rate coming down. Our testing is also kind of back up to higher levels. I don't think that fully contributes to the decrease in the test positivity, but that certainly is a good help for us. And we're seeing total test positives come down. So I think cautiously optimistic at this point that this is our holiday surge, but the next 5 to 7 days will be really telling. The hospitalizations, keep in mind that the surge that we saw from December 30th to January 6th with those really high numbers, those cases are going to be hitting our hospitals essentially now. And so you get tested positive, many times do not hit in the hospital for another, 5 to 7 days. And so we'll still be seeing hospital volumes increasing or remaining high, even if we're going to have a decrease in our cases. And so our hospital volumes are still really high, they're back up to those levels that we were at the end of December, early December. We're back in that range, which is, above the 85% capacity mark across the state. It's the same for our ICUs across Intermountain. And so we're still up at that really high, threshold for our hospitals. But if we have a continued sustained reduction in cases, our hospital numbers will also start to drop shortly thereafter. And that's what we really hope. The deaths, unfortunately, we talked about this last week, is the deaths follow after hospitalizations. And so we had this big rise, and we've had this rise in hospitalizations again. Deaths follow that. And so I anticipate that we'll continue to see high death counts over the next week, at least next week or so.
I have two quick follow-up questions for you. The first one is around the positive rate. I think back to June and July when we had 800 cases a day, and that seemed really high. And we're obviously very far past that at this point. But is there a positive rate percentage that gets us back to a better place as far as community spread? And what is that, if there is one?
So Angela Dunn has said this repeatedly, that our target test positivity is less than 3%. And that would indicate that we have pretty significant control over the pandemic in our community. We've read other places, 5% is also kind of a cut off in terms of a control or not. So, really our target from a test positivity standpoint should be 3 to 5%. And we should keep in mind that some communities recently, last week, had a test positivity rate of 40%. And so we're a long ways off from that. But I think we're seeing a trend of decrease in test positivity. We don't have any big family-based holidays coming up in January and February. And so I'm hoping that we can really drive that community prevalence down during this time period as we're getting vaccinations going up, which is just going to certainly help the transmission within the state of Utah.
I want to talk about the daily deaths that were reported yesterday really quickly as well. I mentioned that 9 of those happened prior to yesterday. According to the report I read, it said prior to December 23rd. Why is there a lag potentially in reporting a death for COVID, and what goes into figuring out if someone actually died because of COVID?
Yeah, and some of this we're going to have to reflect to the state, but from the reports we're reading is that every COVID death is being evaluated by the medical examiner. As you can imagine, those investigations can be pretty lengthy. They have to get medical records. They have to assess the primary cause of death. And that evaluation period by either pathology or the medical examiners takes time. And so the fact that you're seeing these deaths being reported late, I think is just a sign to us showing that, hey, these cases are being investigated by the medical examiner's office, which is a state-based office, to really determine whether or not they're COVID-related deaths. And so I think that part is really important. And the fact that they're not counting deaths a COVID death if that the primary cause of death wasn't due to COVID-19. We see a lot of patients that are getting admitted to the hospital for surgeries or for traumas that come in and are asymptomatic but have a positive COVID-19 test because we just see that amount of community transmission. Those aren't COVID-related deaths if those people end up dying for alternative reasons. The COVID deaths that they're really highlighting here and investigated by the medical examiner's office per report is truly a COVID-related death. They die from respiratory failure or a complication of COVID-19 infection.
I think that's important to note too, especially as more information gets reported. There was also that lag in case counts yesterday, and I think it's important to note that the state is doing their research and looking at data to make sure that everything that's being reported is accurately reflecting what's actually happening with this pandemic.
Right.
Which I think is, and a lot of this information is available on their state site, which we can put up afterwards. I have two quick questions for you about the vaccine. Somebody asked, with all the focus on vaccinations, are we kind of forgetting that we're in this pandemic? Are people getting more relaxed in what they're doing?
I mean, I think the answer to that is yes, right? Because we now have a light at the end of the tunnel. We have an effective vaccine. 95% efficacy in the randomized controlled trials. And I think we have this light at the end of the tunnel, which allows people to become a little more lax. And I think we probably saw that over the holidays with, large family gatherings. I know some of the stories we're hearing from patients admitted to the hospital says, yeah, I had people over for Christmas. We had 20 family members. And then somebody developed symptoms the next day. And now, 2/3 of us are infected. And so I think that is the case. We have to remember, though, that we're a ways off. We're months away from having enough of our population vaccinated to really impact, the healthcare networks in terms of the care we provide to patients with COVID-19 and without COVID-19. And so this is a really important time for us to remember, like, hey, we still have 27% test positivity. We still have lots of community transmission. Utah was 4th highest in the United States just last week. We're by no means out of the woods for this. And we really have to kind of double down on our public health principles of, social distancing, limiting our contacts, hand hygiene, and always wearing a mask if you have to leave the house.
Another question for you around vaccines as well. Someone wanted to know around the distribution for 70 and above. There's been people that are getting vaccinated now that fall into that category if there's availability. Is it more urgent to vaccinate the elderly since they're more susceptible to COVID versus other groups like teachers? What's your opinion on that?
Yeah, so, you think of essential workers, and then you also think of the highest risk patients. Essential workers are important because they're the ones that keep our communities running and our economies going. And so I think teachers are a great example. If we can protect our teachers, which are older than students, many of them are above the age of 55, 60 that are high risk. Some of them have chronic medical conditions as well, and they're being exposed to a group of kids, especially in the middle school and high school, that have high rates of infection. If we can protect those people, then we can feel a little more confident about getting our kids back in school, which has huge implications from a workforce standpoint. And also just mental health from children, getting them back engaged. I mean, it's so important. And so I think that is absolutely critical to get them vaccinated next after our healthcare workers, which really maintain the ability for us to care for patients. And so I think those two are absolutely the right first steps in terms of this vaccine. Now, the reason we go to the 70-year-olds, and there's different variations across the state of where they're putting that benchmark, is it 75, is it 70, is it 65? Regardless, the whole point is to protect the most vulnerable population. Who are the people that are in the hospital the most from COVID-19? Who are the ones that are most likely to die from this infection? That's the elderly. Okay, so absolutely critical to get them protected first. And so what then happens is that takes some of the pressure off of our hospitals to make sure that we can care for people regardless if they have COVID or not. The next group are going to be those that are obviously above 65 and those with chronic medical conditions that put them at higher risk of adverse events if they got infected. And so that first wave is really protecting the most vulnerable. And so that they are not getting sick and dying. The next step is going to be mass vaccination to really decrease transmission across the country.
I have an unrelated question for you as well. There was a couple of reports yesterday around an increase in children's hospitalizations specific to COVID-19. I know you're not a pediatrician, so you don't work specifically with this group of children, but are we seeing an increase of children being hospitalized or having adverse reactions to contracting COVID-19?
Yeah, so what we can say is, absolutely we're seeing more children being admitted to the hospital, especially compared to earlier this summer. The condition of MIS-C, or multi-inflammatory syndrome in children, is a very real thing, and we are definitely seeing those cases at primary children's, and we're actually seeing that kind of syndrome complex in adults as well. And so just because of the sheer volume of children and adolescents getting infected, even though it's a rare event, this multi-inflammatory syndrome, it's a rare event. But if we're having more and more children and adolescents getting infected, we're going to see more of that, and that typically leads to hospitalizations. So the fact that yes, children and young adults are less likely to have a severe outcome, it's not to say that they never do. And we definitely have seen young adults. I'm an adult doc, and so we typically see kids above 18 years of age and above in our hospitals. We definitely see some of them get admitted to our hospitals. We just had a 21-year-old get admitted and had severe disease from this inflammatory syndrome. So yeah, we do see children, we do see young adults getting very sick, but it's at a much lower rate than the adults. That being said, we've had a lot of children and adolescents get sick, so we're seeing them in the hospital.
You bring up children, so I want to ask you around college-aged kids. A lot of universities are starting to go back to school either this past week or they'll start next week. Do you have any advice on what those people should be doing as far as public health measures if they're coming in from out of state, or if they were with their parents for the last couple of weeks and are now going back to a dorm style setting?
Yeah, it certainly makes me nervous, right? So you're getting people coming from all over the US coming to Utah. Utah can't say that we're a low prevalence state, right? We've been in the top 10 in terms of community transmission, for the past month or so. And so I'm not necessarily as worried about, people bringing the virus in. We have plenty of virus here in the state. But what obviously starting college back up increases social interactions in that young group. Think what we saw post Halloween, right? We saw those big parties in Halloween and we saw this huge surge afterwards. I worry that we bring a very large group of young adults together. We concentrate them in congregate settings like houses and dorms. And we're going to get more transmission, especially as those people then take the infection back to their family members. And so it is, concerning in the fact that, hey, we're potentially getting a bit better, but now we're increasing congregate settings in young adults. It's certainly a high risk that we'd see an increased transmission in that age group, which we know then spills out and over into the older age groups, which can lead to more severe disease. Testing, in that population is important. And I know Governor Herbert and now I believe Governor Cox is going to really emphasize that to make testing available for that population. Testing is just one component, one strategy to know whether or not you're infected. It comes down to the fact that we really need that population to minimize large gatherings. We really need that population to always wear masks when they're outside of their homes, to really decrease that transmission amongst that group, which then leads to transmission in older populations. So it's something to watch. It'll be something to watch to see what testing does and how effective that is. But it really is going to fall on the college, young adults to say, hey, we've got a responsibility to our community to really minimize transmission, which includes masking and decreasing social contacts.
You mentioned too that a lot of universities are going to be doing testing more frequently. Because of that, could we potentially see our positive case count percentage go down if we're testing more asymptomatic people? And if it does happen, are there pros and cons to having that be a part of the daily reports that go out?
Yeah, it will certainly affect our case counts. It's going to affect our testing volumes, and it'll affect our test positivity, right? So those markers are really important and good when you've got stable testing practices across a community. If you have stable testing practices and test seeking behavior across a community, you can follow those and follow those trends. We just need to recognize and make sure that we're able to interpret how many tests are being done in those asymptomatic college kids, and what is that going to do to our test positivity? Clearly, if we're flooding our testing market with asymptomatic individuals on college campuses, we potentially are going to see our test positivity come down just because we're increasing tests. But we also may see an increase of our positives because we know that's an age group that is often asymptomatically infected. And so we're just going to have to be really careful and cautious in how we interpret the data once we start doing significantly more testing in that population. And now watching the demographics of test positivity is going to be really important for us. And we'll be tracking that on the state's website pretty closely. So I think, yes, it potentially very well could change our trends. And we just have to be really cognizant of how we're interpreting that data.
And as that starts back up, I know I'm at the U right now, and they're starting that next week, or I think around Thursday. So it'll be interesting. The next time we meet, we can kind of go over and see if that's started any sort of increase for the state. But like you said, it's how you interpret the data and make sure that you're understanding that there's this additional piece in there now. Another question around vaccines for you. We've seen healthcare providers, essential workers, this group of 70 and older are now starting to get vaccinated. Do we need to be speeding up how quickly we are vaccinating people? If we stay at the current trajectory, how long is it going to take to actually get to what we need to be herd immunity?
Right. So yes, it'd be great to speed up. Absolutely, 100%. Healthcare workers have been vaccinated. And so, across Intermountain, we've received our vaccine allocation. Anybody who's wanted a first dose could have gotten the first dose. We're now not offering first doses anymore, and we're now just finishing up vaccine series for second doses. So I got my second dose last week, and then over the next 2 to 3 weeks, people will be finishing up their second dose of the vaccine, whether it be Pfizer or Moderna, depending on where they got vaccinated. So healthcare workers, we're moving past them, and now we're moving into essential workers. And then you're right, they just opened up scheduling for those above age of 70, and they will be starting to vaccinate them soon through their local health departments. And so at this point now, vaccination for those above the age of 70 is going to be all done through the local health departments. We've obviously offered to Utah Department of Health that we are here and willing to help as needed. And so I'd say absolutely, as we should be vaccinated as fast and efficiently as possible. And I really hope that that's what's going to happen, when we start vaccinating our greater than 70s next week. And so we're really going to have to watch those numbers and look at how many people are vaccinated per day. We have the data on the state website. And if it's not going fast enough, I hope that we can, change practices and move into a more efficient vaccination method. Utah can do this. I have no doubt Utah can do this. Utah's very, very good at logistics. And so I'm hoping that if they're seeing that we're not vaccinated fast enough or efficiently enough, that we move into a new process, whether it be mass vaccination, drive-through vaccination, whatever it might be. I hope that that is a direction we take so we can get people vaccinated as fast as possible.
I know there's a couple of counties that have started to do that as well. I think Davis County had a drive-through vaccination clinic for teachers, which is great to hear. So things are moving along. And as you said, Intermountain is working with the local health departments, and we'll put a couple of links for people that are interested to figure out kind of what the next steps are for their group as things move forward.
Keep in mind, herd immunity is a ways off. We're talking 60 to 70, potentially higher % of the population being non-susceptible to, SARS-CoV-2 for us to get herd immunity. And herd immunity really limits the ability for that virus to spread in a community. That is a goal that we hope we can obtain. And we hope we can obtain that through vaccination. And the way we can obtain that through vaccination is that our vaccines provide a long-standing, durable immune response. If our vaccines doesn't stop, transmission, meaning people get vaccinated may still be able to be asymptomatically infected. If it doesn't prevent that, if our vaccine doesn't provide long-standing immunity, let's say it only provides immunity for 6 to 12 months, herd immunity may not be possible, just like within influenza. What do these variants do to our immunity? All these things are questions to be able to determine whether or not we can get to herd immunity. Our first priority is to make sure that we get those people that are at high risk for poor outcomes, that we get them vaccinated to provide a level of safety for those people that have high risk of poor outcomes. That's our first priority. And that means getting the people above the age of 65 vaccinated and those with medical comorbidities. That's our first priority. Then comes this idea of, can we actually get to herd immunity? And so it really is kind of, our goal right now is not herd immunity. That's not an obtainable goal in the near future. Our goal right now is to protect those that are vulnerable.
Around that same idea too, why is it so important for someone when it is their turn to get the vaccine? So that, I guess my question is, some people cannot get the vaccine. Either they're allergic or there's something that they've talked to with their doctor that has said, hey, do not get the vaccine. So why is it so important for those who can get the vaccine to get the vaccine?
I would say it's so important to get the vaccine because, one, it protects you. It protects you from having a poor outcome from this disease. And we know that, yes, the people that are older and have medical condition are at higher risk for having a poor outcome. But I can tell you, we've seen hundreds of people in the hospital that are young with no comorbidities get sick, and some die from this infection. So even if you don't think you are at highest risk, you're still at risk for a bad outcome. And not only that, we see, and we're learning much more now about the long-term effects of COVID-19. There was a study that was just released. It was out of China that looked at patients that had COVID-19, and they looked at them 6 months after discharge, and over 65% of them still had symptoms of some kind of manifestation of COVID-19, whether it be poor sleep, decreased energy. That's a huge amount. And so, yes, even if you don't die from COVID, which is the vast majority of people, there still is huge segments of the population that have long-standing symptoms from COVID-19. So if you can prevent acute infection, you're going to prevent those long-standing complications from COVID-19 that we're learning much more about right now. And so if you have the ability to get the vaccine, get the vaccine. It also is most likely going to be a public health measure. If you protect yourself, you're most likely going to be able to decrease transmission in the community. We don't know exactly what the effect of the vaccine is on transmission and what it is on asymptomatic infection, but I suspect it's going to be significant. And so you're not only protecting yourself, but you're also protecting your communities that you're engaged with.
Along that same lines around protecting yourself for asymptomatic spread, I know that these clinical trials are still ongoing. It's just been about a year since this has started. What's a good date range or timeline when we could potentially get more data that shows us if the vaccine is protecting against asymptomatic spread as well?
Right. So, the first priority for the vaccine studies was to show whether or not the vaccine protected from symptomatic infection. That was first priority because that is what the FDA was going to base their emergency use authorization on. So that was obviously priority number one for all the vaccines and the vaccines that are coming out. We are going to see, and I anticipate soon, more and more data coming from those vaccine studies. The other thing is that there's post-marketing vaccine studies that are currently ongoing. These are called vaccine effectiveness studies that are looking exactly at that. They're doing nasal swabs of people that got the vaccine compared to those that don't have the vaccine to see what the impact is on asymptomatic infection. And so I would anticipate over the next few months, you're going to start seeing some of those studies come out. First, it'll be in healthcare workers, then in the general population. And then I really believe that over the next year to 2 years, we're going to have a flood of information about these vaccine effectiveness studies to really assess how well does this vaccine work in the real world. Are there populations that a certain vaccine works better in than others? And so we're going to be able to really refine our knowledge of these vaccines over the next year or two.
I want to talk about the UK strand that has been circulating. I know there's some cases that have come out in the US of people who have that new strand. Will you just give us an update on what that is, how that impacts our hospitalizations potentially and the pandemic as we move forward?
Yeah, so the UK strain, the UK B117 strain, and then there's also the South African strain. The UK strain obviously has the most attention because it is likely thought to be the reason why we've seen such a large increase in the UK, particularly in the southern part of England. We know that variant likely is more transmissible, meaning it's more infectious. And so that virus is able to bind tighter to our human cells. And because of that, it decreases the amount of virus you need to get infected. So it makes it more infectious and transmissible. In the US, we're seeing more and more reports of this UK variant. The CDC has a website up, and I believe California had 30 cases, Florida had 22 cases, Colorado had 3 cases. Most of these cases are identified in individuals that haven't traveled. And so it just makes us realize that this strain, this variant, is here in the US, and to what extent, we don't know. Angela Dunn gave a Facebook Live yesterday and reported that the Utah Public Health Lab has done significant sequencing of the virus and hasn't identified it yet. And so from my interpretation of that is that we have been looking and we haven't found it. So does that mean it's not here in Utah? No, it just means that it hasn't been identified, and it probably isn't very prevalent here in Utah. It's probably not causing this post-holiday spike. And so I think that's relatively reassuring, but we'd be naive to think that it's in Colorado, but not in Utah, or it's in California, not in Utah. I think it's probably here just at low prevalence rates. The other bit of good news that we got from Pfizer was that they did a study where they took the plasma of 20 individuals that had been vaccinated with their Pfizer vaccine, and they saw whether or not it neutralized the virus. And so they looked at the wild type virus and then the B117 variant, and it showed that the plasma of those individuals that had been vaccinated with the Pfizer vaccine was able to neutralize the mutant virus. Okay, so what that tells us is that this vaccine is going to also protect us from the B117 variant. And so that's very encouraging in the fact that we can continue our plan of getting people as vaccinated as fast as possible. And that will also protect us from the two identified variants, or at least the UK variant. What also works to protect us from the UK variant is our public health, principles, social distancing, wearing a mask. All of those things work equally well, against the UK variant versus the wild type variant. And so that's kind of the current update of the mutant strains. Keep also in mind that this is what viruses do. Viruses mutate. This is 100% expected. We're going to see more of this as we move forward because viruses mutate. That's just what they do, especially in community prevalence situations that are very, very high. You're going to have more mutations because you have more virus circulating. The way to decrease our viral mutation rate is by decreasing the prevalence of this infection. And that includes vaccination and public health measures.
I'm really sorry if you can hear my dogs barking. So a question around that. So airlines just released, or I'm not sure exactly who came up with this plan, but that you do have to have a negative test to come back in the US after leaving. Do you think that could help potentially slow the strain down, even though it's already here, or prevent the US from having additional mutations come into the US?
Yeah, I mean, potentially, I think what it'll do is it'll decrease the amount of positive travelers. And if we decrease the amount of positive travelers, you decrease the risk on airplanes, you decrease the risk at the airport, you decrease the risk of transmission when they return, regardless if you have the mutant strain or the regular wild type strain. It doesn't, take into consideration of, getting tested in the early phase of infection. Your test is negative, then you develop symptoms while you're on the plane, right? Like it doesn't prevent that. And so, closing borders, putting in travel restrictions, those things haven't been super effective across the globe. But what it does is decreases the burden of positive travelers, which I think is a very good thing. And we've seen, travel restrictions, going to Alaska or Hawaii, some of these other places that have been effective for some of these states. And what it does is it really decreases the amount of positive people traveling and positive people entering those states or in this country, or in the state, or in this situation in the country.
Last question for you. Will you just give us an update around therapeutics and how everything is going with convalescent plasma, and how we are starting to potentially treat COVID cases if they present into our hospitals?
Yeah, so the update from an outpatient side is that people may have heard of these monoclonal antibodies that have been approved in an emergency use authorization. There's now two products, one by Eli Lilly, one by Regeneron, which is great because it increases the volume of our supply to be able to offer these therapies to patients. We're offering these therapies to patients that are at high risk of poor outcomes, but have initially mild COVID-19 disease. And so if you come in, you get tested at a curbside testing, or you get tested at a primary care office or in the emergency department, and you're at high risk for a bad outcome, but you have mild disease currently and don't need hospitalization, those are the people that we're targeting for these infusions. And so we're offering them, other places are offering them. And we've done now across the state about 400 infusions. We're starting to look at that data now to look at what is the impact of that medication in terms of decreasing hospitalizations. And so that's a new advanced therapeutic. We know based on the studies that earlier is better for these types of therapies. And so if you get infected, you have symptoms that had just started recently, that's when you'd want the therapy, not after 6-7 days of symptoms. You want that therapy as soon as possible. So if you're at high risk, if you're older, if you have transplant, you have underlying lung disease, heart disease, those types of things, and you have symptoms, it's so important that you go get tested and then see if you're eligible for one of these therapies. And so that has a really good potential for decreasing the need for hospitalization, which is going to then decrease, obviously, deaths and bad outcomes. And so that's a good advanced therapy for us that we're getting more and more comfortable using. And then there's been 2 studies recently published about convalescent plasma, and not just convalescent plasma, but high titer convalescent plasma. So that means they take plasma from people that have been infected with COVID-19, and then they only use the plasma in people that have high levels of antibody. Right now, if you get a batch of convalescent plasma, it's anybody's guess if it's low antibody, medium antibody, or high antibody levels. But in the 2 studies that have been done, one out of Argentina and one here in the US through the Mayo Clinic, it showed that high titer antibodies through convalescent plasma was beneficial in people that had early disease and also non-severe disease. And so we're learning much more about when these kind of passive immunity therapies, passive immunity meaning we're giving you antibodies from somebody else, whether it be monoclonal antibodies or convalescent plasma, is really going to be beneficial in people with early disease and people at high risk for poor outcomes. And so that's going to most likely then, change how we think about convalescent plasma. I'm hoping that's going to change how we acquire convalescent plasma, and we're only getting high titer plasma. And so I think you'll see that evolve over the next couple of weeks to months.
As always, it's kind of a waiting game to figure out what data and research comes out and what we can kind of figure out from there. Eddie, is there anything else that you'd like to mention to us today for an update?
Yeah, I think, we're at this critical junction. We're past the holidays. I'm hoping our case trends will continue to go down over the next 5 to 7 days to really validate the fact that we've passed this holiday surge. If that's the case, our hospitalizations will come down. That stress on the healthcare systems will be lessened. And then it's really going to be up to the public to really minimize your social gatherings with people outside of your homes, because we think that is really driving a lot of this infection. You get the infection in the community, you bring it to your home, and then you're welcoming people into your home and you're transmitting the virus. And so if we can really focus over the next 2 months of saying, hey, let's maintain this pretty strict public health measure about not engaging with people outside of our homes on a large scale and always wearing masks. I think if we can do that, and then as we see the Department of Health ramp up their vaccine distribution, I think we're going to be in a good spot come spring, especially end of March, early April. I'm really hoping that that's kind of the time where we're coming out of this, you know, a year after when we really entered it in full force. And so that's what I really hope we can see out of our communities. So many people are doing this, which is just amazing. That so many people across the state of Utah are abiding by these measures, which is just incredible. And it just shows the commitment to our community. But if we can continue to do that for the next couple months, I think we're going to be in a much, much better place, you know, come end of March, early April.
Well, Dr. Stenehjem, thank you so much for the update. I really appreciate it. And if you would like to know if you qualify for COVID-19 test, you can go to intermountain.com/COVID testing, and you'll be able to take a quick survey to figure out if you qualify, and then you can choose an appointment arrival time at one of our clinics. We also still have our emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. Eddie, as always, thank you, and we'll talk to you next week.
Thanks, Amanda.